Good morning, everybody. We welcome you all. Before the morning CCR, I think it's a welcome for 2024. Wish you all a very happy new year and a new beginning of this year. We have had a lot of good opportunities in 2022-23. Our institute has achieved new heights, done a lot of good new work, and we expect with us. And then subsequently, the chairman of Center of Digestive Sciences, Dr. Namesh Mehta, had joined. What is our areas of interest specifically are laparoscopic surgeries, minimal invasive surgeries, abdominal surgeries. We do most of complex pancreatobiliary PG clinic on Mondays, case presentation on Tuesday, CCR as a regular schedule we have on Wednesday, academic seminars on Thursday, and journal club and subsequently GST on Saturday. We have outreach activities such as Jaipur Swasth Charcha, which is actually a thought process and a baby child of Dr. Kapoor, who had started this. We have started this long back a discussion with the patients who had undergone a bile duct, any lap chole and a bile duct injury. We do a telephonic communication with the surgeon so that we can acclimatize him how to get to prevent it in subsequent future. These are our recent publications. We have something very astonishing to attach to a department which we have received the travel award by the Japanese Surgical Society at Tokyo in 2023, 2 awards. And I'm very proud that we have 2 of these which were on pancreaticoduodenostomy, that is a Whipple's procedure commonly called, which is our area of interest. And subsequently a travel bruisery, and then IASG Best Paper Award, and then a Massicon a Best Paper Award this year. We are now a part of Center of Digestive Sciences. This is a team which formulates, which is under chairmanship of Professor Dr. Namesh Mehta. So I now invite my first year resident, Dr. Hrishikesh, to present this case of a young female. Please.
Thank you, sir. We have, proceeding with the case, we have a 39-year-old lady who is a homemaker by profession, resident of Chaksu, came to us with complaints of on and off pain and generalized weakness for 3 months. The pain was generalized. It was episodic abdominal pain, and it was increasing in intensity progressively, and it was restricting her daily household work, not aggravated on food intake, and required occasional analgesics. It was also associated with generalized weakness for 3 months. She has no history of jaundice or fever, no history suggestive of bowel obstruction, that is abdominal distension, vomiting and obstipation, no history of any urinary symptoms, no history of loose stools, no history of suggestive of any GI bleed. And sir, obstipation is defined as the absolute constipation, unable to pass flatus and stools. She also has no history suggestive of GERD such as heartburn or regurgitation, and she has no history of weight loss. 1 month back, when she was taking intravenous analgesia for pain abdomen, she was diagnosed with hypertension and is currently on 2 tablets for the same. She doesn't have any other comorbidities, and she has no contributory significant family history. So to summarize, her appetite was normal with no bowel and bladder disturbances. Her menstrual cycles were regular. She has currently 2 live children which were delivered normally. Last delivery was 10 years back. So to summarize the history, we have a 39-year-old female with generalized episodic abdominal pain with associated generalized weakness for 3 months and a newly diagnosed hypertension. So to elaborate regarding the differentials according to the specific region, the abdomen is divided into 9 regions. Would anybody like to suggest the most common causes of pain in specific regions? So pain in the right hypochondriac region, it may be due to liver disease, biliary pathology or diaphragmatic pathology. Since patient has no fever, jaundice, and these are unlikely to be present. And She can have peptic ulcer or a pancreatitis if the pain is in epigastric region, and these can still be kept as a differential diagnosis. And if the pain is localized towards the left hypochondriac region, but she has no fever or any fullness in that region, so left diaphragmatic and splenic pathology is unlikely. In right and left lumbar region, it can be attributed to renal or any ureteric pathology, and that she doesn't have any urinary symptoms per se. These both can be are more not likely to be present. And the pain in the periumbilical region is commonly attributed to small bowel pathology or including chronic mesenteric ischemia, which presents with postprandial angina, and also pancreatitis can be present in the periumbilical region. So these can still be kept as the differentials. And pain in the right iliac fossa is the point towards appendicitis, ileitis. Ileitis can be due to tubercular infectious etiology or a Crohn's ileitis and Meckel's diverticulum. Since she doesn't have any altered bowel habits or any history of melena, these are also unlikely. And pain in the hypogastric region can be attributed towards urinary bladder pathology, and since she is a middle-aged lady, adnexal pathology can be a differential, but she doesn't have any menstrual disturbances or any urinary symptoms, so these are also unlikely. And the left iliac fossa pain is towards the diverticulitis or a colitis, but she doesn't have any fresh blood in the stools or also called as hematochezia, and she doesn't have any altered bowel habits, so these are also unlikely. Proceeding with the examination, she is a conscious, oriented and alert lady, well built and nourished with a BMI of 23.2. Her vitals are stable and she has no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. On abdominal examination, the only positive finding was mildly distended abdomen, with the rest of the abdominal examination revealing no localizing signs. Her parectal and periogeneal examination were also normal. So to summarize again, she is a 39-year-old female with a generalized episodic abdominal pain associated with generalized weakness and a newly diagnosed hypertensive, and on examination mild distended abdomen with no localizing signs. So after history and examination, we could not localize the pathology. So we proceeded with the blood investigations. Blood investigations including CBC, RFT, serum electrolytes, LFT, amylase lipase, urine routine were essentially all normal. And we got a imaging done in form of ultrasound abdomen. Ultrasound abdomen showed 3 lesions. 3 lesions, one in right hypochondrium of size 5 by 5 centimeters, one in left adrenal region, which was also 5 by 6 centimeters, and right adrenal region lesion, which was 3 by 4 centimeters. Rest of the organs were normal in ultrasound, and there was no free fluid in the abdomen. I would like to call upon Dr. Yashveer from radiology to give us the radiological point of view.
Good morning, respected teachers, seniors and colleagues. I will be discussing about the radiological aspects of the patient. So as the ultrasound abdomen stated 3 lesions, 3 mass lesions, 1 in the pancreas and 2 in the right and left adrenals. So in these cases, triple phase CT scan is quite advisable, as different mass lesions show different patterns of enhancement and de-enhancement. So this is how a normal triple phase CT scan of the abdomen looks like. So this is the first one is the non-contrast phase, and then what we do exactly is we push the intravenous contrast, and then we take the sections at specific time intervals. So in the arterial phase, we can see the aorta is well enhanced, and in the portal venous phase, and it is less enhanced as compared to arterial phase, but the portal vein is quite enhanced in this portal venous phase, and then we take the delayed section as well to recognize the pattern of de-enhancement. Thank you, sir. So this is the triple phase CT scan abdomen of the patient, and we can see a large heterogeneous lesion, heterogeneously enhancing lesion in the left suprarenal region, and with some sort of hypoattenuation within it, and another mass lesion involving the uncinate process and the head of pancreas is seen, which is also hypervascular, enhancing heterogeneously with some hypoattenuation within it. And another lesion in this section, we can see the lesion, cystic lesion in the right adrenal region, which is peripherally enhancing. This is the coronal section of the same patient, and we can see a left suprarenal mass lesion which is abutting and indenting the left renal parenchyma, and it is in close proximity to the splenic hilum. And this is the right suprarenal region, which is again looks like a cystic lesion with some sort of peripheral enhancement. And this is the pancreatic mass lesion we saw in the axial section as well, and this is in abutting, and it is in close proximity to the superior mesenteric vessels, but no any sign of infiltration is seen, and it seems to involve the IVC as well, but no definite vascular invasion was seen. So the mass lesion was basically pushing the adjacent structure but not infiltrating them. This is the portal venous phase of the same patient, and we can see the left suprarenal mass lesion is still retaining the contrast with some hypoattenuation, and this is the pancreatic lesion with lesser contrast uptake in portal venous phase, and this is the right suprarenal region. So based on these findings, the possible differential diagnosis we can think of is, if we look at the adrenal masses, the mass lesion was taking contrast on arterial and portal venous phase. So it was hyperattenuating. We measure the attenuation in CT in terms of Hansful units, and so on portal venous phase as well, it was showing around 160, and if anything greater than 120, even in the portal venous phase, that strongly suggests the pheochromocytoma. But another differential we can think of adrenal cortical carcinoma, which are mainly unilateral, but this can be the possibility as it was showing some hypoattenuating areas. Some large metastatic lesion can present as the same, especially which are having some cystic or necrotic foci within it. Sometimes hemorrhage also occur within the large metastatic lesion. Some hypervascular metastatic lesion like hepatocellular carcinoma or mets from the renal cell carcinoma can also present the same. And in the pancreatic mass lesion, as the mass lesion was abutting and pushing the adjacent structure but not exactly infiltrating the adjacent structure, so it typically seen in pancreatic neuroendocrine tumors. So the triple phase CT suggests the pancreatic neuroendocrine tumor. However, some hypoattenuating areas point out the possibility of serous cyst adenocarcinoma as well, and some large metastatic lesion can present as the same as we saw in this patient. Now I would like to invite Dr. Jyoti to discuss the endocrinological part.
Thank you, Dr. Yashveer. Good morning, everyone. So this patient was referred to us with history of abdominal pain since 3 months and hypertension since 1 month, along with imaging studies suggestive of bilateral adrenal mass and a pancreatic mass. On retrospective evaluation, patient was not having any history of palpitation, anxiety, headache or sweating. For the further workup of the adrenal masses, we did overnight dexamethasone suppression test, which was normal. Plasma-free normetanephrine were highly elevated, almost 10 times the normal value, leading us to the diagnosis of pheochromocytoma. So pheochromocytoma, along with the pancreatic mass, which could probably have been pancreatic neuroendocrine tumor, led us to the strong suspicion of von Hippel-Lindau syndrome. So we looked into the other components associated with the syndrome. Ophthalmological evaluation was done, but there was no retinal angiomas. Patient was not having any history of hearing loss or tinnitus. No history of any cerebral signs were there, and previous imaging did not reveal any presence of renal cyst or renal cell carcinoma. So we were left with adrenal gland and the pancreas involvement. We advised gallium DOTA PET CT for further delineation of the tumors and metastasis risk. Such patients of VHL with such presentation falls under classification type 2C when FEO is present but RCC and hemangioblastomas are absent. Having said that, we strongly suspected VHL, there might be some other mutations as well associated with hereditary pheochromocytoma. So we sent a hereditary cancer gene panel, and the report of which is now available to us and will further be discussed. I would invite Dr. Mansha from nuclear medicine to discuss the PET CT findings.
Thank you, ma'am. I'll be discussing the good morning, everyone. I'll be discussing the PET CT images of the patient. In our department, we conducted 2 different scans on 2 different dates. The first image on the leftmost side is the MIP image of 18F FDG, which is depicting the physiological tracer distribution in the brain and the urinary bladder, and it is also showing 2 intensely FDG avid lesions in the abdominal region. The middle image is showing the MIP image of the DOTA-NOC PET scan, which is showing a physiological distribution in the pituitary, the liver, spleen, bilateral kidneys, and the urinary bladder. The third and the rightmost image is showing a lesser intensified image of the DOTA-NOC PET, where the yellow arrow is showing an abnormal SSTR expression medial to the right kidney, and there is a hypodense area which is represented by the blue arrow, which is also showing mild uptake of the mild SSTR expression. These are the coronal images of the patient, where the blue arrow is depicting an FDG avid lesion which is measuring approx 6.3 into 7.4 into 7.2 centimeters with an SUV max of 14.16. The same with SSTR expression is 8.5. The yellow arrows are showing a lesion, a hypodense lesion, which is measuring approx 2.9 into 2.3 centimeters. Neither this lesion is FDG avid, nor it is showing any SSTR expression. These are the images, axial section images, which are showing a pancreatic mass, which is approx 5.4 into 6.7 into 4.8 centimeters, with an SUV max of 33.73. The same pancreatic mass is showing an SSTR expression of 23.8. According to our imaging, we can come to a conclusion that this either could be a neuroendocrine tumor of head of pancreas, left adrenal lesion is likely pheochromocytoma, and the right adrenal lesion appears benign according to our scan findings. The advantages of PET CT over conventional imaging are definitely to rule out the distant metastasis, and the DOTA-NOC PET has a better sensitivity and specificity for diagnosis, staging, and response evaluation of neuroendocrine tumors, pheochromocytomas, and paragangliomas. Now I would like to invite Dr. Vinay sir to please take the presentation forward.
Good morning, respected teachers and my colleagues. So how a multidisciplinary or multimodality approach is going to help to diagnose some kind of complex cases. This case is a beautiful example of that thing. After getting all those biochemical investigations, radiological investigations, and with the help of our colleague in endocrinology and nuclear medicine and radiology, finally we got the confirmation and the final diagnosis in form of bilateral pheochromocytoma with pancreatic neuroendocrine tumor. And as all we know that both are major surgeries itself, if we have to plan bilateral adrenalectomy, that is going to be a major surgery because it used to be a lot of hemodynamic changes while doing adrenalectomy. And if we have to combine pancreatic duodenectomy with it, then we have to think seriously and we have to be overcautious. So keeping all these things in our mind, we kept 2 separate plans. First one is bilateral adrenalectomy with simultaneous pancreatic duodenectomy. And if something happened or during the surgery, if major hemodynamic changes will occur, then we kept bilateral adrenalectomy and second stage pancreatic duodenectomy as a second plan, keeping these things in mind that pancreatic neuroendocrine tumor is a slow growing tumor, so we can plan this as a second stage surgery. Now I would like to call upon Dr. Jyoti Sharma to discuss about the further in terms of endocrinology.
Thank you. So having made the diagnosis of pheochromocytoma, preoperative optimization was necessary. This is because in case of pheochromocytoma, there is a catecholamine surge. So we have to control the arterial pressure, heart rate, prevent arrhythmia, as well as to combat the chronic intravolume depletion, to avoid the paroxysmal crisis, and to decrease the intraoperative hemodynamic instability. For this, we stopped the previous antihypertensives and started the patient on alpha-adrenergic blockers. Tablet prazosin was given at a dose of 2.5 mg BD and was titrated till 15 mg per day. The most preferred add-on class of agent are calcium channel blockers in these patients, so tablet amlodipine was added subsequently. Target heart rate in these patients has to be kept at 60 to 70 beats per minute in seated position. For this, beta blockers are added on day 2 or day 3 after the alpha blockade. We have to be cautious that we start beta blocker only after alpha blockade to prevent the paroxysmal crisis. Tablet atenolol was started. Along with these, restoration of intravascular volume is also very important. So high sodium diet is advised, almost 5 grams per day, to prevent the orthostatic hypertension, as well as extra fluids, oral as well as IV. This patient received almost 3 liters of fluids daily. So now I would invite Dr. Saurabh from anesthesia to discuss the challenges.
Thank you, Dr. Jyoti. Good morning, respected teachers and my dear colleagues. Now I will discuss the anesthetic challenge for this case. Our major anesthetic concern were, firstly, this was a long duration major surgery involving major fluid shift and anticipated blood loss. So there is a wide range of hemodynamic fluctuation, mainly in the blood pressure. And hypertension is seen at the time of surgical incision and during handling of adrenal gland, followed by sudden hypotension as soon as the adrenal vein is ligated. And the similar fluctuation are seen in the blood sugar level also. These patients are chronically volume depleted due to the alpha stimulation by catecholamine secretion. So there is a chance of sudden hypotension at the time of induction of anesthesia. And lastly, an important component of our anesthetic management is the pain control, attributing to large surgical incision and the long duration of surgery. Hence our goals are to maintain euvolemia and the normoglycemia, control heart rate and the arrhythmias intraoperatively, maintain hemodynamics. So our preoperative goal to maintain BP should be less than 130 by 80 mm of Hg, with the upright systolic blood pressure should be more than 90 mm of Hg, and the heart rate should be 60 to 70 beats per minute in sitting position and the 70 to 80 in standing position. And lastly, we have to avoid catecholamine surge. So trigger factor for catecholamine surge during anesthesia is the certain drugs like succinylcholine, ketamine and morphine. So we have to avoid these drugs. And we attach standard American anesthesiology monitoring like 5-lead electrocardiography, oxygen saturation, temperature, arterial blood pressure for beat to beat monitoring. And we also use the advanced cardiac output monitoring, which guide us about the fluid management as well as provide the detailed hemodynamic status in terms of cardiac output and systemic vascular resistance. And classically in this case, our fluid management has two opposite goals. After the adrenal vein ligation, we need to administer fluid bolus to maintain blood pressure, whereas in case of Whipple surgery, only the calculated amount of fluid is to be administered because of risk of anastomotic leak. So therefore we use this advanced hemodynamic monitoring for this case. And we performed a standard general anesthesia induction, taking care of avoiding use of any histamine releasing drugs. We secured an arterial line for beat to beat monitoring of blood pressure and the central line to administered fluid, inotropes and vasopressors. We kept all the emergency drugs ready, and we kept all the intravenous infusion prepared in order to deal with any hemodynamic fluctuation intraoperatively. So as we can see in this graph, initially there is a hypertension and the maximum blood pressure goes up to 190 by 109 mm of Hg. So to control this, we administer infusion of nitroglycerin, sodium nitroprusside and the boluses of the injection labetalol. And as soon as the adrenal vein is clamped, there is a sudden drop in blood pressure which goes up to systolic BP 77 and the diastolic BP 40 mm of Hg. So then we use the intravenous infusion of the noradrenaline injection ephedrine boluses and the fluid boluses, and we also did the blood sugar monitoring at regular interval, as there is a risk of hypoglycemia after clamping of adrenal vein. So we have successfully managed this case intraoperatively. Now I would like to invite Dr. Hrishikesh.
So as our anesthetics friend has already discussed about the intraoperative major changes which we are predicting prior to the surgery, I would like to emphasize what kind of surgery we did. With the help of the midline incision, we did a laparotomy, and after careful examination of the entire abdomen and ruling out all those metastases including liver, omentum and peritoneum, and there was no ascites. So we proceeded further, and as our plan, we first approached left adrenal because the left adrenal tumor is quite big, then simultaneously right adrenal, and we did a bilateral adrenalectomy. And while doing the after adrenalectomy, we reassessed the hemodynamically stability, and we waited for at least 10 to 15 minutes. And after getting the green signal from our anesthetic friend, we further proceeded in the form of pancreaticoduodenectomy, and approximately 4 by 3 centimeter firm mass was there in the head and uncinate process of the pancreas. And as a standard of care, we used to do lymphadenectomy, that is the removal of the enlarged lymph nodes at porta, common hepatic artery, retropancreatic and interaortocaval region, all those were removed. So just to summarize what exactly is Whipple's, that is the pancreaticoduodenectomy. Before Whipple's surgery, the anatomy is like in the this diagram, and after doing the Whipple's surgery, that is the removal of the bile duct, gallbladder, duodenum, proximal part of the stomach, and proximal part of the jejunum and the half of the pancreas. The way we used to reconstruct and restore the anatomy in the form of 3 different kind of anastomosis, that is pancreaticojejunostomy, hepaticojejunostomy and gastrojejunostomy. And our center experience of total number of cases is about approximately 101 in last 3 years, and we routinely used to do the laparoscopic Whipple's, and our number is 5. So I would like to just share the intraoperative details. The total duration of surgery was 280 minutes. 1 unit of PRBC was transfused during the surgery. Total blood loss was approximately 300 ml, and urine output while doing the surgery is 600 ml, and surgery remains uneventful. So this is the diagram after removal of the specimen. As you can very well appreciate, there is a right adrenal tumor, is 3 by 2 centimeter, weighted 25 gram. There is a left adrenal tumor, 8 by 6 centimeter, weighted 140 gram. And this middle one is the Whipple's pancreaticoduodenectomy specimen, classical one. This includes gallbladder, proximal part of the CBD, part of the duodenum, jejunum and pancreatic tumor, which is 4 by 3 centimeter. So to further discuss the oncopathological aspect, I would like to call upon Dr. Shikha Goyal.
Thank you, Dr. Vinay. Now I will be discussing the pathological aspect of the specimen we received in our department. We got bilateral adrenal glands with pancreaticoduodenectomy specimen, common hepatic artery lymph nodes, aortocaval lymph nodes, hepatoduodenal ligament lymph nodes. So the histology from both the adrenal glands reveal the similar morphology. So this is an H&E stain section, scanner view showing the adrenal gland on the top of the picture, and this is a tumor showing the cerebellum arrangement of the tumor cells. So what is cerebellum? In the cerebellum, arrangement is like a ball-like arrangement of the tumor cells, and in pheochromocytoma we get this arrangement. The cells appears to be clear with the slightly amphiphilic hue. This is on the right hand side. This diagram is from 100x view H&E stain section from the pancreas, showing the organoid pattern of the tumor cells. So the cells shows a monotony, and they have round to oval nucleus with central nuclei and salt and pepper chromatin, which is a characteristic feature of the tumors of the neuroendocrine origin. So on our histological findings here, bilateral adrenalectomy specimen showing the pheochromocytoma, and the PAR score was 0. PAR score was done basically to assess the risk of malignancy in pheochromocytomas, and it is based on these 12 parameters. And from the Whipple's specimen, the impression was well differentiated neuroendocrine tumor, grade 2, Since the mitotic activity was 2 per 2 millimeter square, all the resected margins were free of tumor, and 13 lymph nodes shows reactive hyperplasia which was free of tumor. So our impression is bilateral adenectomy specimen shows pheochromocytoma with a PAS score 0, and Whipper specimen shows well-differentiated neuroendocrine tumor, grade 2, and according to the PTMN staging, the stage was PT3 and 0. Thank you.
Thank you. With that, actually, though the surgery was completed, and we know it has been long said that pheochromocytoma, I think my guide Dr. S.C. Luda was here as a principal, and he used to always say, it is not you who is doing the job. It is the anesthetist who is doing the job. He is who makes my life comfortable on table. We are just doing a technical part. So we had 3 fronts which were very well controlled. One, definitely thanks to anesthesia team. Definitely endocrine people, pre-operatively, intraoperatively, continuously they have been asking them, and then they have been helping. So that is the second front. And then comes the critical care team. So the patient was shifted in ICU immediately post-operatively. The patient was intraoperatively, since he had a lot of fluctuation, he was on vasopressors, and he was allowed orally on day 1. Blood pressure was stabilizing day 4 onwards, so most of the vasopressors were under control, and lines were removed once the patient was stable. And then we had to give, as we have 2 stalwarts of endocrinology with us, Dr. S.K. Sharma sir and Dr. Rajiv, and they said this patient needs steroid. We knew that adrenal are out, so he needs a steroid. This lady needs a steroid, so she was on oral steroid after that, and she was discharged on post-op day 10 with the oral maintenance. She was followed up, suture removal, blood pressure monitoring, the blood pressure, the antihypertensives required were gradually tapered, and now definitely comes a team of our medical oncology team. So we asked, sir, निकाल दिया है, कुछ करना है क्या आप हमको? And then they said, no, thanks, the job is done well. So we were happy that the medical oncologist said no further requirement. So that gave us a big relief after that at least the patient doesn't require any additional treatment. This is the patient's follow-up.
उन्होंने मेरे को काफी सपोर्ट किया, मेरे को ऑपरेशन मेरा सक्सेसफुल हो गया, मेरे को कोई दिक्कत नहीं हुई. हाँ, हल्का फुल्का थोड़ा सा कमर में दर्द रहता है, बट मैं काफी अच्छा महसूस कर रही हूँ, मेरे को कोई प्रॉब्लम नहीं.
So I think thanks, well-deserved thanks to the entire team. We'll come to that. Before that, let's come to the technical aspect, the academic part. The take-home messages are: patients with the underlying serious medical issues, they may present not with specific symptoms. We had just a vague pain, difficult to diagnose. Definitely ultrasound and then subsequently CT had helped us. A stepwise approach, endocrinologist coming up, intervention, our radiology team coming up, then getting a PET scan done, and then subsequently genetic testing being done. A planning has to be very meticulous, a multidisciplinary approach. I think we don't have many centers which are doing this type of multidisciplinary approach still in the state. A stepwise surgical approach. We had the difficult, Vinay said, it was difficult. Adrenal हम कर देंगे और BP नहीं आया ऊपर. While we are doing adrenal, the adrenal sitting on the IVC. हमारे पास, we have a loss of suppose 2 liters, 2.5 liters. Will we proceed? So we have to plan it. No, we'll call off the day. We'll do it later. Let us see that, let the patient stabilize, and definitely neuroendocrine tumor is not a metastatic, it's just not a very aggressive disease, we can deal it with later also. So that is what we had to plan. So a young patient with 3 tumors requires a good teamwork, and definitely a very big thanks to our management, because we are able to get a good OT team, good instrumentation, good ancillary support of various departments. So very big thanks to management of Mahatma Gandhi Institute, and definitely endocrinology, anesthesia, critical care, radiology, nuclear medicine, oncopathology. They need a very important thanks. And ये जो slides बनी है ना, हमें लग रही है अच्छी है, तो बहुत गंदी बनी थी, बहुत खराब बनी थी. I'm too, बिल्कुल सही बता रहा हूँ. मतलब हम लोगों ने बैठ के हमारी ओर से कोशिश करी थी अच्छी बनाने की, लेकिन फिर पता चला कि इसके अंदर ना एक गलती, हर स्लाइड के अंदर there were at least 2 to 3 mistakes, and thanks. I think thanks to Lalit Mohan sir and Raman Sharma sir and Munish Kakkar sir, and of course Dr. Kapoor sir. मैं ये सारा था ये सब कुछ था. Dr. Kapoor should come and say, and he said, I am at the two coaches right now. One is surgical gastroenterology and one is pro VC. So I can't come over there right now. I will be having a marks. I have to give the marks also. So I can't come on this side. So I have to take this responsibility. Thanks to all the participants and definitely the family members of the patient who had given us this opportunity to tackle with a difficult scenario. And only a handful, maybe must not be even a handful cases being done in the state of Rajasthan. And I'll not be surprised that such a case would not have been done even in North India till now. So I'm thankful to all of you for a patient listening. Thank you all. Thanks. Dr. Rekha is here, so I would request Dr. Rekha to. Sorry, I missed it. That's my mistake. I'm very sorry for that.
So genetic testing was done here, and the mutation came out in von Hippel-Lindau gene, and it was deletion variant in that gene. So one thing important is that genetic disorders are basically familial disorders. So we need to make a awareness in the family that you are suffering from the disorder, but your first degree relatives, your offsprings and your siblings may be affected with the disorder. They may carry that gene also. Because in von Hippel-Lindau disorder, 80% of patients get the mutation from their parents. And in 20% cases, they get the mutation new. But when they get the mutation from their parents, then other siblings are also at risk and parents are also at risk. And penetrance, it means if you get the mutation, then what is the probability of getting the disease? So in von Hippel-Lindau disorder, penetrance is very high. If you get the mutation, then up to the 65 year of age, you will get some symptoms of the disease. And in such cases, if we got the mutation, like in this case we get the mutation, now it's the beauty of mutation that we can identify the asymptomatic carriers in the family without getting the symptoms. So, and last stage of coming the symptoms is 65 years, and earliest symptoms may come in first decade. Dr. Rajiv, if you remember, we diagnosed a 14-year-old girl with retinal hemangioblastoma. Then we did the testing of VHL and she got the mutation. So, symptoms come in first decade. So, if we identify the asymptomatic carriers, we can start the screening from the first decade. And even this disease is not so good. Many systems are affected, and so much of suffering in this disease. So even in such disorders, we offer the prenatal testing and pre-implantation genetic testing also. It means we can diagnose the fetus in the womb that he will be affected with the disorder or not, so the family can take the decision whether they have to give the birth of that kind of baby or not. So this is the important thing in these genetic disorders. So finally, it is an autosomal dominant disorder. 50% chance of getting the mutation in the family. So this lady was 39-year-old. She had 2 offsprings. So they are also at 50% chance of getting the mutation. So they need first the mutation testing. If anyone is affected or getting that mutation, then screening should be started. And even first degree relatives, siblings should be tested for the mutation, because symptoms may come up to the 65 year of age. So they should be tested for the mutation. So who are asymptomatic carriers, they should be put on the screening and further testing also.
ये FTG intake थोड़ा सा ज़्यादा लगा स्क्रीन पे. ये
सर स्क्रीन में पूछ रहे हैं.
So this one?
Yes.
So that is a Dotanog, this is a Dotanog, gallium Dotanog scan. This is an SSTR expression of the normal physiological uptake in the spleen.
Okay.
Yes, sir.
So it was looking very bright.
Yes.
I thought some pathology might be. Okay, this is normal uptake.
Yes, this is absolute normal, sir.
Dotanog, ne?
Yes.
So I have a question to Dr. Ajay and Dr. Kapoor. Can a minimally invasive surgery be contemplated in a patient like this, say for example a laparoscopic resection or a robotic resection?
Sir, with the solitary adrenal we have been doing laparoscopic. Rajiv is here, we have done bilateral adrenal also laparoscopic. Our worry was not doing the procedure. Our worry at this patient was once we do this in a non-hazardous manner and with less complications, and we should be able to complete, if possible, the second part, the PD also. We have been doing adrenals separately by minimal invasive. We have been doing PD by minimal invasive, but combining both, we were a bit skeptical. Suppose something, we were even open, we were skeptical. If something goes wrong, then maybe we'll have to hamper the second surgery. Our target was if we are able to complete both the surgeries in the same setting. Dr. Rajiv,
normal dictum is that 4 centimeters you can take out laparoscopically. Anything more than 4, it would be difficult.
Sir, I think with time the things are changing. With the robo coming in, the world has changed. So I think yes, with the even Manish, Dr. Manish from urology, he said he has removed a few days back. He's removed a huge tumor by minimal. I think that the world is changing. We have to accept it, sir.
The second question. How common is bilateral adrenalectomy with a Whipple's procedure? I think we could have added...
No. So we wanted to add, we thought initially that we will run out of time, so we had actually requested all our resident colleagues to skip some of the slides, run fast, and as by our CCR team, we all faced, when we were presenting yesterday, it was going beyond 1.5 hours. So we thought that we may run out of time, but fortunately, yes, if we anticipated that we could do it in time, I think we would have added that. Before we conclude, I'd like to just emphasize on one of our, the awards part slide now. We got 2 Japanese Surgical Society awards. Yeah. So we got, we have a special area of PD. Special interest in PD, Whipple's pancreatic duodenectomy. We do a lot of Whipple's pancreatic duodenectomy, and we feel happy if somebody tries to challenge us. We feel that हमने कुछ करा है और कोई जना हमारे को कह रहा है कि ऐसा कैसे हो सकता है. When Dr. Kapoor sir joined, I think he was also the feeling that how can we start oral on day 1. Sir is there, I think he is, and all our team is there. And now most of the centers in the country have accepted what we started. They are now doing oral feeding on day 1. Most of the centers are doing on day 2. Day 1, many of them are coming, and we have shifted. Our resident team is here. We have shifted from day 48 hours to 24 hours to 12 hours to 8 hours post-operatively oral feeding. So I think that is what we are progressing ahead of the world, and we are thankful to our team, not only our team over here, but critical care team who is there sitting over there in the ICU to manage that. And I think the time will come. The laparoscopic cholecystectomy. The picture, I agree. Laparoscopic cholecystectomy, we still ask the patient to stay overnight, but in many of the centers, they admit the patient in the morning and discharge by evening. The world is changing. We have to accept it that yes, we have to go fast now. So that is time-saving procedures, and we save on anesthesia, pre-operative, post-operatively. The pre-operative, we used to keep fasting for 12 hours to 18 hours earlier. Now we keep fasting for 6 hours. The world is changing. I think we have to agree to it. Thanks to our team. Thank you all for patient listening. Special comments by Dr. Swankar, sir. Yes, sir.
Publish kara.
Sir.
Publications ke liye, I think.
Sir, this has already gone. This early feeding has already gone for a publication, and air leak test. Both of them have gone for a publication. We have some queries from them, and I think we are solving on that, sir.